From the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
Welcome to our program, and today's topic is addressing national health issues and policies. There's been much discussion in recent months and years, and this is certainly one of the very, very important issues in the lives of all Americans. And we're most fortunate to have on the program a man today who's highly qualified to discuss this important national issue. Welcome to the program, Joe Morris, who is the CEO of the Kootenai Medical Center in Coeur d'Alene, Idaho. He has been with the Kootenai Medical Center for approximately 20 years, and I certainly can testify to the effectiveness of not his work there, but also his work on the region and around the country. He serves as the chair of the American Hospital Association's Policy Board for Region 8, which is the Mountain States. That also places him on the governing board of the American Hospital Association. Joe, we've had you on the program before, and we're delighted to have you back to talk about, in very general terms, a really major issue. Welcome to the program.
Glad to be back.
And as always, I'm pleased to have regular panelist Janelle Burke, who is an attorney in the state of Idaho, and we shall ask Janelle to commence today's questioning on this issue of health care.
It's a pleasure to have you here to discuss what I consider to be, in my opinion, one of the very important issues facing us today. That is health care in the future and policy issues relating to health care. What do you consider probably to be the three greatest issues that are facing the healthcare industry today?
I could probably list 15, but if I were to boil it down to three, I think Medicare is a significant issue. The Medicare Trust Fund is out of money the year 2002, and that's the health care program that covers the senior citizens and the disabled in this country. I think a second one would be the growing number of uninsured. 2 years ago we were debating national health insurance. Now we're going the opposite direction, and there are trends that would indicate that would go quite a bit higher in the next few years. And I think thirdly would be the growing influence of Wall Street over health care, both in the ownership of physician practices, hospitals, insurance companies, HMOs. We're not seeing that as much in this specific area, but around the country that's become a significant issue.
Let's go back to the first of those issues, that is the Medicare issue, and tell us something about how it affects your hospital. And I'm talking about now what kind of an impact does Medicare have on the Kootenai Medical Center at this time. I would understand that probably the impact that it has on KMC is typical of the impact that it would have on hospitals across the country.
We are fairly typical, and although the senior citizens in Kootenai County might be 13 or 14% of our population, they're half of our patients. And so it's half of what we do today, but half of our beds are filled with Medicare patients. So Medicaid, which is a state program, is 9%. Commercial insurance is 34%. So Medicare is our single biggest payer, and how they pay us and how they treat our hospital affects to a large degree how successful we are.
So that's one of the issues. The second issue that you were talking about was the uninsured person. How does that affect your hospital? And I would again assume that that's fairly typical of hospitals across the country.
Well, it affects our hospital because whoever comes through our doors we take care of, whether they have the ability to pay or not. And so if there's a growing number of people who have no ability to pay for their health care, those are costs that we incur for which we're not reimbursed. If that number continues to grow both nationally and regionally, then it puts more of a burden on hospitals specifically, because often we're the safety net of the community and the provider of last resorts, certainly at our emergency department, but throughout the hospital.
And the third issue, can you explain for the benefit of our viewers a little bit more what you mean by that Wall Street-driven market?
Well, healthcare has been traditionally a cottage industry. Each town had their own hospital, locally owned. Either in Idaho, they're mostly governmental, but a lot of non-for-profits. The current trend is that there's been a growth on the for-profit side, and so there are a lot of hospitals who, in their community, they're owned by a national corporation. The national corporation has stockholders. You know, they need to pay attention to the needs of those stockholders as well as the needs of the corporation, as well as the needs of the community. And so that's affecting, I think, the way that hospitals sometimes relate to their community. In the insurance industry, we've seen that, at least say in California in 1985, most insurance companies were nonprofit. 91% of the dollars they took in went to pay benefits. Now most of them are for-profit. About 76 cents on the dollar now goes for health care. Others go for, some of the other dollars go for administrative costs, for profit. And then more recently, there's been a buying of physician practices. National corporations who buy up physician practices, manage those practices, try to get their hands on the insurance dollar, and if they can cut down on utilization, they keep the rest of the money. And so I think Wall Street has discovered that there's, because of some inefficiencies in healthcare, there's a potentially large profit to be made by insuring people, by running physician practices, and by operating hospitals.
I want to take advantage of, excuse me, of the fact that you're a member of the American Hospital Association Board and you discuss all these policy questions, and your organization also lobbies for particular policies and legislation. And so, Joe, let's just delve into some national trends. You indicated earlier in the program that Medicare would be broken, or maybe that's before we got on the air, by the year 2002. What do you see, one, as the basis of the problem, and two, what are some of the possible solutions? Or are we going to address those solutions in the near future?
It depends on who we is, of course. In Congress is usually the we we're talking about. But Medicare has a Part A and a Part B section. Part A trust fund funds hospital care, outpatient services at healthcare organizations. Part B funds physicians. Part A, which is the larger fund that funds the hospital side of things, at the current rate of spending will be out of money at the year 2002. And so our country's going to have to decide whether you put general revenues into providing that service. And the general problem is that you're spending a lot more money than you're bringing in through the payroll tax that is imposed upon both the employee as well as the employer. And so given that, there's one of several solutions. You can reduce expenses, and to do that you can cut down on eligibility, say that someone has to be 70 instead of 65 to be on Medicare. You can cut down on the number of folks who may be eligible for Medicare, cut down on the disabled part of things. You can increase co-pays. So you either have to raise revenue, which is increasing taxes, or cut expenses. The more popular way to cut expenses in the past has been to cut reimbursement to doctors and hospitals, but sometimes the problem there is that as reimbursement is reduced, folks are no longer willing to take care of Medicare patients. And so that's the basic problem. I think what the American Hospital Association would propose is that, and it's based on the assumption that Congress cannot come to a coherent solution in the near term, that it's been, as you'll notice, this election a very partisan issue, and so no one's doing anything other than pointing the finger on Medicare. Our proposal would be to appoint an independent commission, somewhat like the base closing commission idea, where being a nonpartisan commission made up of maybe non-politicians, that they look at the revenue side of thing, the expense side of thing, and then the huge demographic problem that our country is getting older and more folks are going to be eligible for Medicare in the future. And then come back to Congress with a recommendation as to how the program should be restructured, and ideally have Congress either vote it up or down. And it would be my feeling that it needs to be done within the next year after the election. And our biggest fear is that Congress will wait until the year 2001 and do something silly that doesn't make any sense, that's destructive to the whole system.
I appreciate your knowledge on this subject and also your recognition of the growing problem. And I'm at a disadvantage with you because I'm not the expert that you are, but I can see at least the complexity of this. It's not one of those issues that has one simple solution. As you were talking, something just really came to mind. If, for example, if part of the solution was raising from 65 to 70 the eligibility for Medicare, many people retire at 62 or 65, or many people cannot work beyond that for health purposes now. And if they are not eligible for Medicare and they have to carry some kind of private insurance, which is prohibitive on their retirement, are we moving then in the direction of having more uninsured than we have now? You indicated before the program too, I believe that in the next 4 to 6 years that we may have 6 or 8 million more uninsured. So it's a very long involved question, but would this kind of solution also might magnify that problem?
Well, a lot of the solutions that we come up certainly with politically ends up magnifying the problem down the road. We just don't always think through those solutions to that degree. On the Medicaid side of things, welfare reform will mean that there'll be a lot of legal immigrants who won't be covered by Medicaid. So that'll increase the number of uninsured. I think increasing The age for Medicare will increase the number of uninsured. Congress has passed some fixes for the insurance system, but if it makes insurance more expensive, then more employers will drop it, so it'll increase the number of uninsured. So 2 years after the last presidential election, national health insurance was a big debate. Now there's really no discussion that I saw in the debates that were held recently under the healthcare side of things. And potentially we can go from 40 million currently uninsured in this country to 46 million by the year 2002. That's what a recent study would show. 25% of those are kids, and so that's probably the largest growing segment of the uninsured are children.
But I guess what I'm suggesting is that then if we have something like this particular provision, then that would add other millions that probably uninsured. I talked to a lot of individuals that after they retire, if they have to carry their own insurance, that's like $500 or $600 a month for major medical coverage. So it's just a really major quagmire, I guess, that we're in, isn't it? And so, but let me just ask one other question and go back to Janelle. This commission that the Hospital Association has proposed, I would assume would probably look at maybe a series of solutions rather than just trying to suggest one. There would be a package of different proposals.
Well, I think it would have to be a fairly large package, looking at when should you be eligible for Medicare, what should the Medicare benefit by, look at means testing. Should the very wealthy get the same Medicare benefit as the very poor, or should you have some type of means testing? How do you pay doctors? How do you pay hospitals? Would have to be looked at, and we expect to take some reduction in all of that, but we think it has to be part of some overall solution, not just a temporary fix to buy one more year on the trust fund. And so I think it would be a fairly comprehensive package. And what we should do as a society is say, what are we willing to spend on the elderly when it comes to Medicare? And then once we know how much we're willing to spend, what kind of benefit can we buy for that? And we really don't do that. We sort of make small decisions that lead to much larger problems.
I want to apologize to Janelle because you have triggered another question. I will do one more. I've heard you talk about this on some panels, Joe, and you're just so articulate about it. As we see the rising cost of everything in life, including medical care, and as you indicated, people living longer, and another good news is that more children survive at birth and so forth, but that creates more medical attention. You have talked about hard decisions in the medical field, and would you spend a little time on, and there's ethicists and ethical committees that are trying to deal with this. Are there some areas that we also have to address where individuals are not going to recover, and how much of the resources can we put? I've heard you say that we can only put so many eggs in that basket, the medical care basket. Would that rather disjointed question, would you elaborate upon that?
Well, we don't. The state of Oregon tried to do that. They tried to look at how much money is available. Then they went through a sort of committee, citizen meeting, series of things throughout the state, and they came up with what are our priorities from healthcare. And then they went down the line until they ran out of money, and then they covered those priorities. We don't do that anywhere else in this country, and so we, instead of covering immunizations, we cover open heart surgeries. For people who maybe will buy them a couple more years of life. And so somehow as a society we need to make those decisions. What's occurred is that decision has been forced on the hospitals and other organizations to have patients show up, and then we decide whether we can afford to take care of them or not as they come through our doors. And so it has to be, I think communities and society in general needs to prioritize where they're going to spend the money and then develop a plan for doing that. But we spend a lot of money on high technology, not a lot of money on keeping people well, which in the long run would be better off if we did that.
Thank you, Janelle Burke.
My question is somewhat related to Tony's question. You often hear people say, I know someone who's been sick and their costs were very, very high. How do you as a hospital administrator respond to those questions? I think that's both a public relations question and also in a way a policy question as to how do you respond to what many people consider outrageous costs of medical care.
I probably respond very defensively. I just would first respond as an institution, saying that our costs at Kootenai are low for the area. They're certainly one of the lowest in Idaho of hospitals of our size, and so we've tried to manage our costs to the extent that we do. Then I would also, when a businessman asked me that, I'd say, well, imagine running a business where you have to provide a service to anyone who shows up, no matter whether they're going to pay for it or not. There's nothing you can repossess. You have to be open 365 days a year, 7 days a week. If a flood or electricity goes out, you have to continue to operate. You're in a highly technical business with a lot of science involved, and so you need to have very qualified, inexpensive employees. And so I think you get value for the healthcare dollar that you spend today. One could argue that maybe we do too much in healthcare, but for what you do pay for, I think you get value. And if you look at how we provide healthcare, lengths of stay have gone down. We do a lot more things on the outpatient side than we used to a lot more things in the home. And so we've taken a lot of the care out of the institutions, which are the most expensive part of healthcare, or at least quit keeping people overnight. Now there's been a reaction to that. Congress then starts passing laws saying how long you have to keep people in the hospital, which again will drive up cost. But I think our healthcare system from a science and technology is the best in the world, and that's why world leaders come to the United States for some of their healthcare. The problem being that level of technology and care is at least not available to everyone, at least or they don't have coverage, health insurance coverage, to be able to participate in that. And even though we take anyone who walks through our doors, there have been studies have shown that the uninsured wait longer, show up later in the course of their disease, die more often, have more positive pathology than the insured have. And that's really, I think, the issue we have to address.
My next question has to do with the large number of people who have entered the field for profit. And we're hearing some criticisms of that, as well as, no doubt, there are people who favor that kind of a program. What do you see as some of the pros and cons for a program that is for profit as opposed to a nonprofit program?
I mean, in this community, you see the nursing homes are for-profit nursing homes, most of them owned by national corporations. There's some other companies, home health companies that have come in that are for-profit, and they need to compete. And then one would say that if they compete based on service, price, and quality, as you compete in other areas of our society and in the free market, then you have to be good to survive. Healthcare, though, the demand isn't quite direct. The consumer doesn't always know as much about the healthcare they're consuming as they know about the gasoline they're buying. They don't know about the prices when they're involved. It's usually a third party is passing the dollars on, and so it's not coming out of the person's pocket, and so they behave differently than they would otherwise. At Kootenai, we make a profit, but we take that profit and we put it into equipment, building. We use it to provide free care. We use it to subsidize Lake City Health Care and some other community programs in town. And so our money stays within the community, whereas in a for-profit organization, what profit they do make leaves the community and goes to the stockholders who are paid dividends or goes to acquire new businesses. And so healthcare, and there have been some good articles by a number of authors. New England Journal of Medicine, their July-August editions had a series of articles on the for-profit versus non-profit side of healthcare and what the different incentives are. And of course, I have a bias in that regard since I'm in a governmental hospital, and in Idaho you have very few for-profit hospitals. But it seems to me that we truly answer to our community, and we're owned by the community. And so if we don't do a good job in taking care of the folks who live in this area, then they can have the right to elect a new board, just like they elect a board at the college.
One of the criticisms has been that perhaps health care would be cut back in order to recognize the profit. In other words, a patient may not be treated as long or as extensively as they need to be treated in order to make sure that the profit side of the balance sheet is favorable. Do you think that's a legitimate complaint, a legitimate criticism?
I can put on, and I'm also on the Blue Cross of Idaho board, so I should disclose that. And Blue Cross of Idaho doesn't make very much of a profit in providing healthcare services. I mean, they have some investments that generate some interest, but they take in $1 from an employer and they pay most of that dollar out by providing healthcare. The for-profit insurance companies have come under, I think, attack, and so the solution has been to pass laws that sort of micromanage how long people can stay in the hospital. And so the HMO bashing, the managed care initiatives that have come from the legislature and in Congress, I think are a result of at least some stories of folks having been in denied care in some form or another, and most of that denial of care has been on the for-profit side of things because you're torn. Do you spend the money, or do you keep the money for a profit?
There's another issue that arises that would not be under your jurisdiction, but there has been some debate in the country about what percentage of profit there should be for organizations that have a relationship to the whole process, but they're not part of the hospital, they're not part of the doctors, and that has to do with the whole field of medication and drugs and the profit with drug companies. From your viewpoint, should there be review by any legislation that deals with, when you're dealing with the health of individuals, should there be some regulation concerning the level of profit that helps also in the controlling of this medical cost?
I think the problem is it's a slippery slope. When you start controlling someone's profit, and where else in our society do you start controlling profit? And we're such a free market oriented country that I think it's difficult for us to do that. The argument the drug companies will give you is that we produce most of the new drugs produced in the world. The reason those new drugs are produced is because they spend millions and millions, hundreds of millions of dollars or billions of dollars on research, and that research produces results. And if they didn't have the profit motive, that research wouldn't occur. And these new drugs would not occur, and new cures would not come about. And so I'm sure, would argue that that's not the case, and that eventually, as patents run out and things become generic, the market drives prices down. Now, certainly as a hospital, we buy our drugs in conjunction with 1,200 other hospitals in a group purchasing program, and so we get good prices on the drugs that we buy. The people most, I think, susceptible are those who are buying drugs individually at the pharmacy. And even there, certainly the managed care companies have cut deals. They're national organizations that all they do is get good rates on drugs from pharmacies, and then as you join a health insurance plan, you get access to those good rates. And so I'm not going to be too critical of the drug companies in particular, because there are hospital chains that have a goal of making a 15 to 20% profit year to year to year.
I guess what it brought to my mind is that as you're talking about this national possible solution to this problem, actually it may not be a solution, but at least checking some of the concerns that we have concerning such areas as Medicare funds and whether there'll be enough available. But I think I hear you saying that when you talk about there are hospitals and there's clinics and there's medical doctors and there's drug companies, so forth, there's a lot of different components of health care, and there's nursing homes and so forth. Does that add to the complexity of a commission like this to do a study, because these are operating independently of one another, and therefore does that not complicate a policy?
Well, it complicates things a lot, but if a commission is doing specifically with Medicare essentially sets prices. And they set how much they're going to pay a doctor, how much they're going to pay a hospital. It varies in different regions of the country, how much they're going to pay for outpatient tests. And so Medicare, because the federal government has the ability to set prices, which they do. And so I think that takes away some of the complexity. The problem is that because Medicare is such a large program, the government will pass some payment policy and not realize what they've done, and it'll spur a whole new industry. So all of a sudden discovers where the money is. And so all of a sudden you have a lot of different organizations going into that particular area of Medicare. I mean, an example would be home health. In this town, when I first came, there's one home health agency in Coeur d'Alene. But if it's an unlimited benefit, no patient copay, then there's a chance to have a lot of volume at that. And so now there are 14, 15 home health agencies in Coeur d'Alene because they think that there's money to be made. And so you probably need to have caps on home health and copays and do things to incentivize the patient to use less.
Joe, I just couldn't have you here without giving you a chance to use that expertise, which you've already done on the program, but Janelle and I might be in error to leave out something that's developing that's of great significance. And I would like for you to take this opportunity to talk about, from your advantage point on the National Board of Hospital Associations, what other issues are of great importance that we have not addressed on the program?
Well, there are some regional differences. I tried to highlight the national ones, but certainly the issue in California and Texas and the Southwest is dealing with immigrants, illegal immigrants who come across the border and then get sick and show up at the hospital. I think in the mountain states there are some rural issues. How many rural hospitals will survive the next 4 years as things become more competitive, as hospitals are used less, as there's pressure on reimbursement. And so I think you'll see a closure of rural hospitals. And certainly in the mountain states, I used to think I knew what rural was until I went to an HA board meeting. The guy in New York was talking about his rural hospitals, and rural to them was a town under 500,000. So now we talk about the hospitals in the Mountain States as frontier hospitals to differentiate them from the New York definition of rural. And so that'll be a big issue in the Mountain States, and I think a lot of Idaho's hospitals will struggle to stay around, and I think a lot of them will not be around when the next century occurs.
Would this be also a component that you would put into this national nonpartisan commission to another one of those problems, and you and I talked about this before, that do we have to have different rules or policies that recognize the difference between urban medical care and rural medical care?
Well, we do. We currently do have differences, but often it's been driven by who has the votes. And so the House of Representatives, which has a certain urban flavor to it, tends to put in Medicare regulations that favor urban areas. The rural hospitals, and I think Congress has paid some attention to rural hospitals, and so they are being treated a little differently under Medicare. They get their cost, and they don't come under the same system that we come under, even in Coeur d'Alene. So there have been a different set of rules, but even given those, I think the question will become, both for insurance companies as well as Medicare, is you pay an artificially high amount to a hospital for the care of their patients just to keep them open, or do you take the view that if there's not the volume, they should sink or swim based on how many patients they attract? And so it'll be, I think, a significant issue in the next couple of years.
Janelle, we have a couple of minutes.
One of the questions that I want to ask has to do with a new project that KMC is undertaking, and that is the regional hospital. A regional hospital that now has a branch elsewhere, and perhaps you can inform the viewers about that and indicate whether that is also a growing trend across the country.
Well, certainly there's a trend for hospitals to work together and to be in regional organizations, and we have our North Idaho Hospital Consortium of the 5 hospitals in the 5 northern county, in Bonners Ferry, Sandpoint, Kellogg, and St. Mary's. We're putting in an interactive video as we speak with the college to link those hospitals together. We operate 3 of them off of our computer system, and so there is a regionalization of hospitals, although we're separately owned. I just came from a meeting on Monday of some Idaho hospitals looking at how we can form an Idaho hospital system and maybe even share some resources and some services. In Post Falls, our strategy has been to put the services where the patients are instead of asking the patients to always come to our institution.
I have to interrupt on that note. I wished I did not have to, but Joe Morris, we'd like to have you back. We just got started, and this is a terribly important issue, and we'll ask you to come back and share with our viewers more issues on health care.
Glad to have been here.
Ladies and gentlemen, our guest has been Joe Morris, who is the CEO of the Kootenai Medical Center in Coeur d'Alene, Idaho. He's also a member of the American Hospital Association's Board of Directors and the chair of the Mountain States Policy Board. I know you've found this most informative, and we will have him back to discuss some other health issues in the future. I would like to invite you to be with us next week, and we'll discuss yet another issue. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.